You are muted.
On camera, you look nice, and the angle is good. What is not available after the session publicly will be our chat. So don't worry about typos. Just go ahead and share and learn together. The slides will be emailed to everybody after the session from the Canadian Patient Safety Institute. So practice this chat function because it's a very important one. Go there and tell us where you're from, your city or country, and what role you play. We're especially interested to know how many patients or family members we have on the line today. So with quick housekeeping, I want to turn attention over to our moderator for today. She's a volunteer member of Patients for Patient Safety Canada since 2006. And you know what? Give me a moment here to get that message. She had been a volunteer patient partner for years. So thank you so much. I need to publicly recognize and thank you for that. It was a very tragic incident, the loss of her son, Daniel, that changed the course of Teresa's life and brought her into the patient champion role of the World Health Organization and with Patients for Patient Safety Canada. She's the lead of our Knowledge Transfer Working Group. So if you've been on past webinars, you already know Teresa. Teresa, it's such an honor to have you here. Thank you so much for moderating this call.
Thank you, Iona, and I'm very delighted about our topic today. And as we're exploring for new topics, antimicrobial resistance and stewardship seemed to be something urgently that we needed to address. I'm call it AR, so I just don't have to keep saying that long word. So AR, we certainly know, has the potential to affect all of us, as all of us eventually are going to be patients. And there will be a link provided to stories of people who've been affected by antimicrobial resistance. And certainly we recognize that AR is a natural phenomenon, but we also know the way that we use drugs affects how this proceeds. Sure, we have treatment for minor injuries and surgery and infections, but using in a wise way is what happens here. Lots going on around the world in organizations, and we believe that patients have a big role to play. And you see these are the objectives that we're going to try to cover. Seeing that everyone will go away with one usable idea that they can start to use right away. We want to just quickly look at some definitions so we all are coming from the same place. Antimicrobials are those drugs, such as antibiotics, that we use to treat infections. And you can see it also includes antivirals, antifungals, so all of those things we really rely on in our healthcare. Antimicrobial resistance is when those microbes learn to adapt from having been exposed to drugs. This occurs naturally, but can also be as a result of misuse of those drugs and compounds. This is to the extent that there's a list of medicines now that are no longer effective in treating infections and made worse by that there are very few new medicines being developed. So certainly this is an urgent issue to discuss. Antimicrobial stewardship is actions that people and organizations take to protect and conserve antimicrobial drugs. This responsibility primarily rests with health professionals and their prescribing partners, but certainly the public can have a big role as a steward or a protector of antimicrobial drugs. This antimicrobial stewardship also applies to agriculture and the environment, but that's not something we're going to address today. Patient advisors are those people that step up to bring the patient voice into healthcare organizations, to governments, to shape decisions, policies, and practices. Typically, they're former patients, family members, and they have a passion for bringing the patient voice forward. And engagement is when we get involved in our own healthcare, in our own health, and in healthcare systems. Those are sort of the background terms that are going to be present in all of the discussion We're hoping today that we will have a very interactive discussion. We've sent your questions on to the speakers, and they will be addressing those questions in the comments that they make today. As Iona said, certainly put your questions in the chat box. So 3 speakers that I'll introduce as they come up, but we also have 3 special guests that we're quite excited about, and they are going to help us in the discussion periods to focus the questions in addition to your questions, so we dig as deeply as possible in the time that we've got. And our first special guest is a lovely picture there, is Dr. Warren McIsaac. Delighted to have Dr. McIsaac here today as he brings the perspective of a physician who works regularly with antimicrobials and their consequences, and he's also a researcher who's looking for answers and solutions. So about that. Our second special guest is Janine Thomas. Janine has worked tirelessly to raise awareness and educate the public about antimicrobial resistance. Her passion arises from herself being critically ill from RSA infection, sepsis, and C. difficile. And it stopped her. Since 2003, she's shaped many attitudes, behaviors, and changes around the world, and we're very glad to have her be part of this conversation today. So you see that long list there. And third, you can see very fun person is Dr. Greg Jane. He's had lots of impact through innovative work through him and his team in the Canadian province of Prince Edward Island. It's caught the attention of those who practice in this field. Dr. Main and his team have engaged the public through social media and awards, bringing life and a human face to their efforts. So we look forward to hearing from him today, too. So I think we're ready to move on to our first speaker. And this is Kim Newdorf. I know her well. She's also a member of Patients for Patient Safety Canada. And she comes to this topic from her family's experience with sepsis, infection, and antibiotics, but also with her deep connection to a community in Saskatchewan, which is a province in Canada. And there in that province, unfortunately, infectious diseases are very prevalent. Kim's a patient partner, a patient advocate in many Canadian-level initiatives, and over the years she's contributed to the evidence in this field and including the article that will be the basis of her presentation. So over to you, Kim.
Thank you.
I will be in the background trying to let you know about time. So go ahead.
Good. Thank you, Teresa. Okay. In January of this year, Margaret Chan of the World Health Organization stated that antimicrobial resistance is of the utmost urgency. This year, a pivotal one. We have a global action plan, and what we need now is action. So 2016 is almost complete, and while there is much more to do, there has been action. And there's a growing recognition that bringing in action must include the patient, the public. In order to take action, there must be an understanding of what the problem is. Therefore, today's goals for this presentation are to introduce you to antimicrobial resistance and stewardship, and Lisa has provided you with some introductory definitions. Secondly, to share the results of our survey published in the International Journal of Health Governance, with the goal of enticing each of you to engage deeper in antimicrobial stewardship personally, and perhaps even with involvement on a larger scale within your communities and nations. In this presentation, I'm going to be using the term providers, and when I say providers, I'm referring to doctors, nurses, dentists, pharmacists, nurse practitioners. Reason in our country to be concerned, the 2016 Canadian Antimicrobial Resistance Survey report identified the following microbes as the first order of priority, and I'm only going to speak to 3 of them. This one is Clostridium difficile that has been already mentioned this morning, and it's increased in the past decade. There's been a significant significant illness and death associated with this organism that causes diarrhea, and it's particularly troublesome in the elderly and largely a hospital-acquired infection. The next one is Neisseria gonorrhea, and there's been a 43% increase in reported cases since 2003, with resistance to a whole range of medicines that have been used to treat it. One is MRSA. It causes tissue infections and is considered to be one of the most common causes of hospital-acquired infections. It's decreasing, but it remains higher than we were at in 2007. A little bit of background to this paper. Maybe I'm just going to go back, actually, sorry. This one. I do have a couple of references at the bottom. In 2015, there was a report titled Antimicrobial Resistance in G7 Countries and Beyond. And you'll see the reference at the bottom of the slide. And it indicates that there is a growing body of evidence that shows that there is a relationship between the use of antibiotics in the first 2 years of life and the obesity epidemic, because of the way that antibiotics affect the microbiota of our gut. So it's another good reason for us as Canadians to pay attention to antimicrobial resistance and stewardship. And the last reference at the bottom of the slide is in province Saskatchewan. HIV is on the rise, twice the national average, and media reports indicate that it is 8 to 11 times higher in our province's First Nations communities, reaching some of the highest levels in the world. Some strains have developed baseline resistance, but fortunately, there still are effective antiviral drugs that are available to treat it. In our study, we wanted to understand patient advisors' viewpoints of antimicrobial resistance and the threat in our country. We did a literature scan and from there developed survey questions. 72 respondents, and they participated from various advisory networks across Canada. 50% had university degrees. 7% were between the ages of 45 to 64. So represented highly engaged members of the public that are interested in improving health care. We have reason to be concerned, and our results indicate that we are concerned. 97% of patient advisors view antimicrobial resistance to be a serious and growing public health threat. Obviously, we don't want to get infected, and we don't want to infect others. We know inconsistent practices, though, of staff in hand washing, the removal of gowns and gloves, and in the cleaning and disinfection of equipment. And we hear why this is. There is inconsistent information, for example, in the use and now disuse of antibacterial soaps. The information is inconsistently shared about diagnosis or fit into a health facility's infection control prevention measures. From our study, this quote, parents and grandparents, I'm constantly concerned about this and how to treat and care for them with less resources and such uncertainty about what is best. Indicate that patients demand antibiotics, the pull, and expect a quick cure for common viral illness infections that do not require an antibiotic. And reports that physicians push prescriptions for antibiotics when there's uncertainty in the diagnosis, or because they think a prescription will satisfy the patient and maintain a good relationship. We found that some patient advisors avoid antibiotics at all costs. The 2016 Canadian Antimicrobial Resistance Report states that approximately 65% of Canadians filled a prescription for an antimicrobial in 2014. Children between the ages of 0 and 9 years received the greatest number of prescriptions, primarily ear infection. Often, these do not require an antimicrobial. Next most frequent users, female urinary tract infection. Again, Antimicrobials may or may not have been necessary. There are a spectrum of behaviors related to the expectation, prescriptions, and use of antibiotics. And as a parent, I'm entirely sure we are demanding antibiotics. Attention to what the parent is really saying. It may be we want a confirmed diagnosis, or we want permission to give our child Tylenol every 4 hours without feeling like we're bad parents. 2% of patient advisors believe antimicrobial stewardship is a shared responsibility. We do to other patient safety initiatives in this country, and we do so with impact. Yet, only 19% of patient advisors were aware of initiatives that were co-designed with patients. And from our study, I've been asked by my local hospital to speak to buyers about my story with hospital-acquired infection, MRSA. I have missed several times with very good feedback. Most of us want to play a role in our own care, but the barriers, there are barriers, our lack of knowledge, our lack of health literacy, confidence, entities, and socio-demographic factors that hold us back from engaging while we make other aspects of our lives priorities. And provider barriers where the provider wants to gain control of the situation, where there's lack of time for decision, their own personal beliefs, and minimal training in patient and family-centered care. The advisor said, we want to be informed and not treated in a way that paternalistically assumes it's better not to worry the patient or the family. I want to be empowered with the knowledge of what I can do to prevent transmission. Patients identified the best way for the public to become engaged in the issue of antimicrobial stewardship and resistance is through one-on-one conversations at the point of care. And I think that this is probably one of our most significant findings in the survey. That providers understand our own unique situation best, including what diseases are prevalent in our community. Conversations about prevention and the importance of using antimicrobials correctly builds our health literacy and helps to engage us. Advisors were largely unaware of several national antibiotic awareness campaigns, yet they view campaigns to be useful to get broad messages to the public. With campaigns, there should be a consistent main message tailored to catch the attention of a diverse public in diverse ways over an extended period of time and includes patient stories for impact. That engage both the provider and the patient in another favored strategy. During Microbial Awareness Week this year, the CDC, Center of Disease Control in the United States, encouraged outpatient doctors to publicly demonstrate their commitment to antimicrobial stewardship. Using Meeker's study as evidence, patients are exposed to a simple poster in the examination room. The poster explains why antibiotics will not always be prescribed and may, in fact, be detrimental. It is signed by the provider as a pledge to the patient. Canada has developed something similar, a letter shared with parents explaining why an antibiotic is not being prescribed and further explains antimicrobial resistance. Canada Choosing Wisely campaign is designed to help providers and patients understand that it is not always necessary to receive antimicrobial for sinusitis, for example. Post statistics for the public to interpret was seen as the least effective strategy. Results showed best understand when questioned. We are healthy when we need care. And there are multiple opportunities to discuss antimicrobial resistance with your patient and the public. Results showed that providers are the most influential resource. They're in an ideal position to influence patient behavior. Once we buy in, we become influential peers, and friends, patient groups. Through our conversations with friends, family, and the community, we have a snowball effect. You tell one person, and they tell one person, and may tell a person. Learn. Patient has identified many things they wanted to learn about antimicrobial resistance. These are the top 5. We want to know what to expect during the course of a common viral illness, like an ear infection, and how long it will take to recover. We want how to prevent the spread of microbes, how to take antimicrobials correctly, how to remain healthy when receiving health care, so we can prevent getting an infection while hospitalized, and how serious antimicrobial really is. We want the facts. Patient advisors can partner in the education of the public and of health professionals. We can co-design of resources, policies, improvement initiatives, and in research. And we can design and participate in public campaigns. Leaders will play a key role in establishing the culture for patient engagement, in shaping the environment to make room for us, and in adding resources. The goal of this presentation will engage each of you in action. At the level, each of us can talk to our provider and ask whether we really need that antibiotic. Of course. We have to recognize and manage common viral illnesses, demanding antibiotics, and prescriptions as directed. We should share antimicrobials with family and friends and work towards preventing infection by having food properly, have safer sex, wearing needles or IV drug use equipment, IV status testing, participating in hand washing measures and vaccination programs. And we have how to dispose of these drugs appropriately. We can family and friends and share anything that you've learned today with one other person. On a scale, patient public may consider participating in your region's patient advisory council. Province, public representatives sit on health professional regulatory bodies. We have a voice at this table as well. Consider giving a talk at your local community group. At the national level, we are fortunate to have public representatives sitting on several national committees, such as National Patient Safety Consortium and committees associated with Canada's Federal Action Plan on Antimicrobial Resistance, and at the Canadian Patient Safety Institute and the World Health Organization in bringing you this message today. Acknowledge co-authors of the paper, Iwana Popescu and Sam Hussey of the Canadian Patient Safety Institute, and some people and of different organizations that are listed here that provided us with information on and resistance. Providing you with several resources. Many of these are favorites of mine for patients, selected from my files. And I hope that you find something useful for the public and for the patients that you work with. Thank you much.
Wonderful. Thank you. That's a wonderful start to our discussion. I'm going to turn to Warren and Janine and Greg. Do you have any questions for Kim at this time? Do we have Warren, Janine, and Greg unmuted?
Yeah, I have a question. It's Janine.
Okay.
What percent now do you have of antimicrobial stewardship program in hospitals? I know in the U.S. we still don't have that many, and we know it needs to be in every healthcare facility. So if you could elaborate on that.
I do it the best that I can from one of the committees that I am involved nationally. And from what I understand, largely the antimicrobial stewardship programs are more in the tertiary hospitals, that is, teaching hospitals. So these would be the larger hospitals in some of the larger cities. And so that is a goal as well, to reach out antimicrobial stewardship programs. Antimicrobial stewardship programs are part of a Accreditation Canada's direction, and it is a goal that hospitals in the country have antimicrobial stewardship programs. Of course, there are many, many smaller hospitals, and so there is a challenge there. So I invite anybody else to be able to add to that definition I provided.
Thank you for that. And we'll look chat room. Warren or Greg, do you have a question for Kim? You, if that's Warren or Greg. We can't hear you.
And to fix that situation, maybe we can recommend to Greg and Warren to use the chat to share some of their experience and ask any questions. And pay attention to the chat, and we can bring them their voices back on the line in a few minutes.
Okay, great. And I'm looking for questions there. I wondered, that's a wonderful list of resources. Is there a particular one that's being used most widely in Canada? And there are site resources I'm going to go and get. But could you talk a little bit more about those?
Well, one of them that is new and is from the Institute of Safe Medication Practice and was developed alongside a patient or two representatives. So that's one that I particularly am thinking of right now. And it talks about 5 questions to ask about medication. And I think, and so it's designed for patients, and I think it is very appropriate in this context. The United States has one as well. I think it's through the CDC, and it's a little bit more specific. 5 questions you can ask about antibiotic prescription. And so those 2 resources, I have several. There's one that I always promote, and it's by APEC, and I'm not going to get the acronym correct, but it's APEC, and it's called Infection Prevention in You, and I would like to see it in every health facility, and it gives information for the patient. It's an infographic that describes how they can be safe in a healthcare facility. And so I do really particularly like that one. I also like the one that's developed in Arizona, and it's a little booklet on essay. It's a patient guide. It's about 13 pages of chock full of information, and I really like that one as well. So those are a few off the top of my head.
Good. Thank you. And those resources are on your resource list that will make
They are, yes.
Wonderful. Good.
I also mentioned that CATIE, C-A-T-I-E, again, the acronym that will escape me, but has excellent resources on HIV for Canadians. So that is another favorite site as well.
Good. Wonderful. So I think we will move on to our next speaker. Garance Upham brings a global perspective to this webinar today. We're delighted to have her with us. She elevates us to understand how patient partners play a role at the international level. Garance has had a lot of experience to share, which stems from her own personal experiences and a lifetime of involvement with the healthcare system, and decades, you can look at her work in infection prevention and control, and this began in Africa and then expanded to a global level. She has contributed to many discussions, resources, initiatives, and policies, and it's a privilege to have her here today. So, I will pass this over to you. Go ahead.
Well, first of all, you hear me because I had a technical problem and I lost the privilege to go through the computer, and so I had to be called back via my phone. So you hear me correctly?
Yes, I do hear you clearly.
Okay. So since the previous speakers emphasized stewardship, I'd like to discuss other aspects. I think that patients have to get involved into the broader prevention as patients and citizens. Let me start with one area that I've been spent a lot of my life on, which is infection prevention and control, IPC. I was struck at the time of the Ebola epidemic last year and the year previous to see that on the WHO website we talked about healthcare givers getting contaminated, patients having Ebola, but the other round was never mentioned, not even once. And I know from my previous work in Guinea, my companion was from Guinea, and I worked sometimes in the past in Guinea, and I still have many contacts with people in Guinea, that they have a very big problem with patient-to-patient and patient-to-healthcare givers and healthcare givers to patients transmission of Ebola. Once a dangerous pathogen gets into a healthcare structure, it is very difficult unless very hygiene are taken to protect people, which is why patients have to be aware, because if I quote WHO figures from Dr. Nedita Alekhanzi last year, who is the person at WHO in charge of IPC, we still have, even in Europe, 23 countries without proper systems of infection control. This is enormous. It's particularly terrible in developing countries, in very poor countries like Africa, or the poor part of China, the poor part of India. And we saw recently the devastation of MERS, the Middle Eastern respiratory syndrome, for example, even in a very wealthy country like Korea. So my first, a few things that I think are important for patients to know. One is that it is amazing how in this day and age, infection prevention has been talked about for several generations since World War II, and in the presence of AMR, that we still have waiting rooms the way we have them. In Europe, we have multi-drug resistant tuberculosis, and MDR-TB is spreading, and XDR-TB and totally drug-resistant tuberculosis, for example, coming from Eastern Europe, Russia, coming from India, throughout the Asian subcontinent. We have that problem in Africa. We have that problem worldwide. It's one example of an airborne infection. Of course, we know about the flu, we know about other infections. As our drugs work less and less, we should be aware that prevention comes first. I'm still shocked to see waiting rooms in emergency, places in hospitals and in the individual, your family doctor. He welcomes you because you have a cold or your child is sick, and you go into the waiting room that has no airflow, in which you're more likely to catch the other person's pathogen than to be cured. So this is a way in which the medical establishment has been overusing drugs. Drugs were a solution to everything. And now we have antimicrobial resistance. We see that drugs are not the answer to everything. Another comment I want to make is that last week I was invited at the Codex Alimentarius meeting in London, the new task force on AMR. And trees with their member countries. There were the organization like WHO, the FAO, or the organization like the International Organization for Animal Health, the OIE, and the private sector. And there were only three of us out of 100 people representing civil society. And Consumers International and the war were there. I see from the discussion is, how do we protect people from contamination by drug-resistant pathogens via the food chain? You can see there that there's very little emphasis that has been placed yet on the proper management of waste. We are releasing, companies manufacturing pig meat or pharmaceuticals are releasing their waste just that into the environment in China, in India, and this dirty water are the breeding ground for drug-resistant bacteria, which will then travel worldwide. One example was the NEM1, the New Delhi, first identified New Delhi, but it's not particularly New Delhi, gene of resistance that can transfer resistance to a whole variety of bacteria, which tomorrow we could have worldwide epidemics of diarrhea, for example, against which no drugs will work. And nothing is being done about the environment. So I myself endeavored to try to present the MR issue in the World Climate Meeting, but, they just didn't work out. But the fact is that, people have to be much more concerned about prevention. I mean, resistance to drugs always existed. Fleming talked about it when he found the first antibiotic. It existed. Now it's getting a lot worse because of bad overuse of antibiotics. And the fact it's getting much worse means automatically patients with drug-resistant organisms will end up in hospitals. And there's a danger that the transition of those drug-resistant pathogens will go from one patient to another patient, will go from caregivers to patients, and will travel all the way around unless we are a lot more serious on infection control in healthcare settings, a lot more serious about prevention in the environment. I'll stop here and take questions because I don't know about my time.
You've raised some huge issues, and I'll pass this first to Warren, Janine, or Greg, and I hope we have Warren and Greg back on the line, or we'll look from our three guests.
And again,
okay,
I just want to say I agree with everything you say. There's not enough emphasis on prevention, and our slogan is certainly prevent saves lives, and this is really what most of these infections are preventable, and not enough is being done with hand hygiene, decontamination of surfaces, and prudence of antibiotics, but these are preventable illnesses, and we really need to focus on prevention.
First job in the World Health Organization, as a consultant, was in injection safety, and that was 5 years ago, and we still had estimated 6 to 8 billion dirty injection practices a year in healthcare. If you look at the situation, because of the economic crisis in 2008, many countries have had to cut down on expenditures in healthcare services, in training, supply, funding for hospitals, so forth. So the situation has not made tremendous improvements since then, which means that patients are put at risk of hepatitis, of HIV, of any pathogen, and including the drug-resistant pathogens. So clean health care is a really important issue for us. And if I may, I want to raise another issue, which is this too much of once doctors are aware of resistance and patients too, then the problem is switching to latest drugs. We took from, I was in Bangladesh earlier this year. It occurs in Bangladesh, it occurs in the US, it occurs in France, it occurs worldwide. Doctors will prescribe the latest molecule just in case the person is resistant bug. And this is really wrong practice, because the more we use latest stuff, the less we will have it for those patients who are indeed resistant. So the other thing that patients can do is really put pressure on our governments and our healthcare staff to demand more on biogram, to demand more diagnostic tests, and to throw some antibiotics to a sick child or a sick elderly person in danger, but then immediately ask for tests to know if that drug is ordinary, or if that bug is resistant and what it is resistant to. You know, if you're middle class in Bangladesh, they give the latest drugs, which is insane. I mean, antibiotics work very well. And we have the same problem from, I was told in confidence by one of the leaders in the ECDC, which is the European Centers for Disease Control, that this is really common practice in Europe. He said he couldn't write on it publicly because, you know, we have to be, you know, diplomacy. But this is a major problem in the Netherlands. It's a problem in Copenhagen. It's a problem in Brussels. It's a problem in the European Union. And so we have to be very serious. And I think patients can play a role. And looking for specific diagnosis would also prevent medical staff from passing a medical error as a drug-resistant bugs, which exist today. And I've been warned about that from very, very old factors of study of antibiotic resistance. Point. I'm talking too much, maybe.
Thank you for that. So in terms of prevention, is there... Go ahead.
Hi, it's Greg German. Just wanted to touch up your point. So from Prince Island, we've been able to use that local antibiogram information, guidelines, change prescription practices by reducing moxifloxacin, one of these big guns, by 70%, and we've seen our C. difficile decrease by 30 to 40%. So it does involve engagement and making things easier for the physician or the other providers across the board, and it does involve peers saying, why are you prescribing that? Because we have guidelines now, and we've seen a renaissance of antibiotics we haven't used that much, such as doxycycline for chest infections or interferon-tone, even in the elderly based on new evidence. Thank you.
Thank you.
Yeah, it's very important.
Okay. I think what we're going to do now is go on to our third speaker, and then we'll come back to a general question period. So we are delighted to have Robina Kayatiri-Tia join us today, and Robina brings a very unique perspective. We will be able to learn from her today and her experience in Uganda. She knows how big a burden and how costly this issue is, and that all people have a role to play in the solution. Robina is the executive director of the Uganda National Health Consumers Organization. She has a lot of experience in right to health and has worked in the healthcare sector for over 15 years. And she is also a WHO patient safety champion. So I'll turn it over to Robina, and then we'll follow with our final question period. So, of your questions. Over to Robina.
Thank you very much. I will begin by talking about the role of patients and patient families and communities overall. This means that we need to put patients at the center of managing and owning their own health care. The challenge in Uganda, I was listening to largely the antibiotics. In Uganda also the biggest challenge is malaria. It is the biggest killer. We have seen it kill like 320 people per day in this country. So managing, and the government has introduced a range of regimes. We have shifted from ordinary chloroquine. We have gone because of resistance. The challenge is that communities are not taking medicine as prescribed, and it stems from lack of information and understanding and appreciation of resistance that in terms of taking lives, but also the cost, the financial cost both to the family and to government. So how the solution would be to get patients to appreciate the simple ways of understanding what biotics and do and how you can work towards malaria can be prevented, but also take medicine to do, you would. The challenge, of course, in this country is that we can buy even prescription medicine over the counter. There is no time when you cannot buy, although the law exists. So the difference between the practice is another matter. That there exists, we buy all sorts of medicines over the counter. So poor people, because they are not, they want to buy. When they are sick, they go out and buy drugs. I can buy them in amounts. So you buy a quarter of a dose if you have malaria, but also because you are not able to test, you do not know if you have malaria, so you go buy and start. So patients have the biggest role in prevention, but also in making sure that they follow instructions. And what we have done is mobilize them around patient groups. Of course, there's also pneumonia for young people and pregnant women, diarrheal diseases, sepsis, meningitis, TB, and STDs and STIs. The STIs and STDs have a special challenge if you look at mobilizing community. Largely, the young people who are our biggest population, these are areas where you have a lot of stigma attached. So empowerment of communities and young people is extremely important, that they are able to approach service providers and have an honest conversation on what the challenges are, but also for us community advocates and champions, that we are able to meet them at community level and be able to have them open up, analyze themselves in two groups and follow up individuals and make sure that they are taking medicines like they do. The government has put in place certain strategies like for TB, to address resistance. We have the directly observed treatment where you have groups follow up individuals and make sure that they are taking medicines like they should, that they are being supported. They have support groups who counsel them and map and spend time with them, but also ensure that they are taking medicines on time. It's been expensive, but it has been useful in following up each patient. When we have directly observed treatment, you follow up each patient and make sure that they are supported to be able to take medicine on time. But of course, stigma is a big issue. That if you have a group of people following you in your home and making sure you take medicine, there is a lot of stigma attached, similar to HIV and all the STI and UTIs. But as long as communities can be taken through processes of appreciating what it means to go counter and buy medicine, but thereafter and how you have to deal with them and how it will cost you in the end. The challenge is that resistance is a process. It does not happen overnight. So sometimes they don't know when it happened and where it came from and when it started. So we introduce some sort of record keeping for and patients, that they have a basic record to know what happened and where it came from and be able to address it. We are also building capacity of service providers in terms of engaging patients. That we have mechanisms, we built-in mechanisms where and providers can come together. We use a tool called the community scorecard. It brings them together to look at what indicators for resistance. How do you know that you have a challenge, you have a problem and it has grown over time? What are indicators that you want to see when you are successful? What success look like when you go to a community and resistance is being addressed and patients taking responsibility for their own care. But also to get patients, health workers, to appreciate the needs of the individual patients and families. Because the challenge has been the instructions that are given by service providers. And to patients to understand that when you have an antibiotic, you need to know that you are taking 2 times 3, which means that you measure the time as you know that if you take medicine, you need to give it 4, 5, 6 hours in between. Sometimes the patients are not looking at time. Even educated patients, when you remember, you take 2. When you miss another 8, 10 hours, then you take another one. So we are getting them to have a record to say, I took my medicine at 8 a.m. Now I have to take another one at 1:30. Health workers have to give clear instructions so that the patients are sure, but also to give them, most importantly, to give them the side effects, but also consequences if you do not take medicine like you are supposed to. The consequences, if you buy half a dose and go and the counter, pick any medicine that you can buy. So empowering patients, but also building mechanisms for them to engage service providers, and finally to have a patient groups support those who are at home to be able to understand treatment has been extremely important. Awareness and information, engaging service providers, and promoting prevention and managing their own treatment. The other area is the role of community leaders, that they need to, because community leaders have the opportunities to speak. They can use those opportunities to talk. Usually they are talking politics, they are talking agriculture, they are talking farming. We want them to also be able to talk to people when they get that opportunity, teaching them to talk to people and distribute posters and materials that address not prevention but also compliance to instructions. And we are working on with Parliament we have already submitted a draft bill on the right to health, which will address the private sector, that the private sector is not selling medicine as and when they want to over the counter. So believe that when the bill becomes law, there will be enough regulation that prescription medicine is not given over the counter. That also unqualified professionals are not selling medicine even in the marketplace. That everybody who has a pharmacy has a paid person who can prescribe medicine. The communities can see and know that a pharmacy has opened in our area. It is by a professional and can hold them accountable, and they have a license pinned on their wall showing that supposed to operate, and they are not as and when they. And community leaders can also help monitor those who have licenses, those who are operating, and exactly what they are. I think, in brief, that is what happened.
Wonderful. Thank you, Rovana. You've given us a very large perspective. We have just a few minutes for questions, so I'll look to our special guest. Have a few quick questions before we finish up.
Ivana, what we're going to do now, and we need the help of all participants, is to unmute all the lines to find Dr. Warren McIsaac's line. So
you are no longer muted.
In the conversation too. So Janet will unmute your lines, and Dr. Warren McIsaac, go ahead. Warren? You're unmuted and we should hear you now.
We're not. Have we lost Warren?
I thought there was going to be more slides.
Okay, hi. I'm unmuted now. You got me?
Yeah,
Go ahead.
Great. Thank you very much. What a fantastic presentation. I mean, there were some great themes around the consumer's role in raising awareness about this important issue, activism in affecting regulations. And I just wanted to speak to something that's come up a lot, and that's really the interaction that occurs between the provider and a patient, and the communication that occurs between them. And there's been several communication issues, some around eliciting expectations for the encounter, others about providing clear instructions, and those are all fantastic points. I just wanted to awareness about a new trend that's happening, and we're hoping to promote further with our education of health providers, and that's something that's been termed communication skills training, where physicians and providers are trained better start this discussion with a person when in to talk about their concerns and fears, and also information needs to really get a more effective decision about in a shared manner about the decision to provide an antibiotic or not. The other point I wanted to make is just reminding that there often is a very high level of uncertainty when people are presenting with some of these infections in the community. And I think it's important to keep in mind there is that very important role of the patient to inform their provider if you've decided not to take antibiotics, that your illness as it progresses over time and changes, that you're informing the provider of changes, because the decision about antibiotics may need to be changed. Just final point being, just reminding everyone that antibiotics are extremely important in the treatment of serious infections, and our goal is to decrease their unnecessary use. There's still going to continue to be a very important need for these medications as we move forward.
Thank you very much for that, and we have come to the end of our time. And I think, Iona, can you mute all the lines there as we just finish up? I think what we've heard today is this is a major, huge issue. There are shared responsibilities that we need between patients and providers, and I love Warren Isaac's point about it's around effective communication. We use this resource widely and ensure that it continues to be available. Iona, you have a final comment? We've lost Iona.
Well, we're going to send
You are now muted.
to everyone after the call to tell us what we can do better next time, apart from audio, and share the slides and the resources that we have collected for you for the webinar. We have some excellent resources that were shared in the chat box, so thank you to all who participated in the chat conversation. Thank you to all the special guests and the speakers today. On behalf of the World Health Organization and Patients for Patient Safety Canada, we have to work to keep care safer, to bring the patient at the center of the fight against antimicrobial resistance. So thank you all for joining us today. We'll be.
Can I say something?
Yes.
I just, I started a newsletter, French, English, and Arabic on AMR, and I really would love to receive information and news items from patients. So it is yours also. So please send us information. We'll circulate it. We have thousands of subscribers, and it'll be my pleasure to give more voice to the patients. We cover scientific news and international news, but we have very few input from patients. We would like to have that, so please send us news items.
Thank you for the generosity to help us work together on this.
Thank you all.
Wish you a very beautiful day or evening wherever you are.
Thank you.
Thank you.
Goodbye.
Thank you.
Bye. Have a nice day.
Yes,
Don't think you hear me or no, but
yes, we can hear you.
can you really?
Thank you. Bye.
Goodbye.